coverage in Nigeria, National Health Insurance Scheme itself, challenges of making quality drugs accessible for the attainment of UHC. Then we'll go ahead to PROF solutions, and then I'll try to introduce you to National Health Insurance Schemes Medicine Supply Initiative, which was, being midwifed by the entire stakeholders, right, in the health sector system. Everyone was involved. Then I'll try to conclude. In a brief introduction, access to quality healthcare products is a key priority globally. And so that cannot be underestimated. Therefore, availability, accessibility, acceptability, and affordability of products of assured quality, especially medicines, in our journey towards EAC is very paramount. And this is alluded to by SDG Development Goals 3.81. So to show that a quality assured medicine is very critical in our journey towards UHC. So any effort to improve, let's not look at the dimension of UHC. There are 3 dimensions that is very important. If you look critically there, we are trying to cover population, and it all depends on the amount of resources you have in that box, which is colored in the inner box. That will determine what the extent of which you are going to cover your population, the benefits that the population you are covering will benefit. That's what we call benefit package in health insurance ecosystem. Then, what is the cost of providing those services? So as the amount of money you have, right, increases. Oh, okay, thank you. As the amount of resources you have within the box increases, you are able to increase, right, the coverage in the 3 dimensions. Just by way of brief introduction, I'm sure we all understand that. Now, what have we done as a scheme in our journey towards UHC, and to try to ensure that we have quality assured medicines? First, in terms of population coverage, based on that box, we have mostly covered at inception till now the formal sector. And the formal sector here refers to government workers. We all understand that in health insurance, right, for there to be coverage, for you to have a coverage, there must be a premium. So if there's no premium, there will be no coverage. So for those who are paying their premium at that level, formal sector, we have covered them 100%. But at that point also, beyond the formal sector, we also have other people of citizens of the society. They are not gainfully employed, right, by government. So we call them informal sector. And that is where mostly the population of Nigeria is captured, the informal sector. And we all know it's between 60 to 70%, and they all dwell in the rural areas, not even the urban center. So we also have a program that covers that, either in form of community-based health insurance program, but of recent, through the operationalization of the basic healthcare of the National Health Act, right? In operationalizing, we say we have basic healthcare provision fund. That fund is being implemented on the platform of state social health insurance agencies. They are the one, when the money comes in from federal government, we disburse directly to the state health insurance agencies. That program that I speak to you, in over 32 states across this country, vulnerables are being covered, and Nigerians who are logged in are being covered. So that is the informal sector. We also have the organized private sector. Of course, also after that, sorry it's not here, you have the private health insurance, where those who can afford to buy private health insurance from HMOs, which are actually licensed by NHIS, are able to access healthcare. So there's coverage for that group of Nigerians who are rich enough to buy health insurance for themselves. And organized private sector, of course, that is talking to about big companies, multinationals, pharmaceutical companies, and so on. Some of them also are able to log in either directly to NHIS to buy health insurance for their workers, or to the private health insurance mechanism through the HMOs. Which of the services are covered? Remember the benefit package I spoke about earlier on? Virtually, what is contained in the benefit package, which we price ourselves to be very, very robust. If you compare it with the benefit package that you have in national health insurance schemes in other countries. Ours is very robust, except with few exceptions. So most of the ailments or diseases are covered. And how much of the cost covered, either in terms of drugs or in terms of services, For what is contained in our benefit package, it is 100% covered with a few exceptions, which I mentioned in a little while. 90% of the drugs required, either for procedures or for normal treatment of your common ailments such as malaria or whatever or the likes, they are fully covered. However, 10% is not covered for obvious reason. It's called co-payment to stem the abuses by enrollees. So that is introduced into the system just to ensure that there are no abuses at that level. Now, there is partial coverage in terms of investigations and some and I will explain that briefly. Like MRI, CT scans, those are high-tech investigations, right, that are very expensive. In health insurance, what we do is that we cover half, that is 50% of the price, while the enrollee pay the remaining 50%. And certain services such as if you have a kidney patient who needs to undergo dialysis, yes, we agree we have not done very much in that because we only have in our benefit package just 6 sessions for the enrollee. And after that, the enrollee is on its own. But plans are on their way through the current leadership of, okay, 10 minutes. All right. Of the current leadership to reform the system. So as the resources are available, we improve the benefit package. Now, what are the barriers towards UAC? Critical among them, we're all aware, is poor infrastructure. I don't need to explain that further. High out-of-pocket payments. That is, in Nigeria, if you look at it, it's said to be between 60 to 70%. That is not an ideal situation at all. Because everyone seems to be paying for health care for himself. Majority, really, seems to be paying. Even in rural areas where you have the facilities, they are either not accessing care in those facilities because of certain challenges, such as, maybe lack of workforce, in those facilities, or even infrastructure, or whatever the case may be. Then you also have, because of the expenses, high costs of the nature of providing costs in Nigeria, we all know if you have to attend private hospitals, what it costs you, right? And also there are shortages, inequitable distribution of qualified medical, I mentioned that a while ago, and then high cost of quality medicines. Quality medicines, if you want to have quality medicine, it's not cheap. And with the inflation currently in Nigeria, the prices just kept on rising. Sorry, I have to run because of the time I have. For you to have, in our journey towards UAC, for you to be able to have quality assured medicines, you must have a resilient health system that supports that process. Vis-a-vis, ensuring that even your supply system, the distribution chain, the right system, it's working very well. So we need a robust health system, and that speaks to the fact that you must have the 6 building blocks functioning synergistically. In addition to that, the 7th one, which you can now call the software, but they must be working synergistically and seamlessly. National Health Insurance Scheme. When the law establishing us said that we should provide cover for all Nigerians, UAC, we are given that mandate. In fact, at inception, we were given 15 years to do that. In year 2000. By 2015, we are supposed to have provided universal health coverage. But of course, the very law also was an impediment because it made health insurance implementation non-mandatory. That suffices that every Nigerian, we either join if you are willing. If you are not willing, nobody can force you. But thankfully, that is being changed. And that has narrowed our coverage to formal sector and to those who are basically paying premiums at the moment. And the key objective of the scheme is to ensure that Nigerians have access to good health care, which of course, for you to have good health care services, you must have quality assured medicines, being dispensed to the patients who have enrolled in the scheme to access health care. And to also protect families from financial hardship. Basically, this is talking about financial risk protection for the citizenry, for individuals, and for families. And to ensure high standard of health care services delivered to all Nigeria across the spectrum. Now, in the government next level agenda, thankfully, the issue of non-mandatory nature of health insurance is being addressed. And as I speak, we have a bill that is trying to address that, which has been, which has reached concurrence at the both level of National Assembly, and the bill has been passed. It's now on the Mr. President table. Once that is approved, there will be mandatory, coverage, mandatory participation of all Nigerians, through health insurance. That's through one form of prepayment systems or the other. And then also to ensure that there is uptake of health insurance coverage in Nigeria. Like I said earlier on, the National Health Act has been operationalized to Basic Health Care Provision Fund, where billions is coming in through government to pay for the vulnerable. And so as I speak, thousands, hundreds of thousands within states are enrolled and are covered, and also ensuring that during this coverage, they have access to quality assured medicines in the course of our journey towards UAC. Now, what are the challenges of making quality drugs accessible for the attainment of UAC? There are a few of them here that we have highlighted. Limited availability of drugs and products, that is true. Because of time, I won't expatiate much on that. High cost of drugs and products, that is pricing itself. And that is, this particular point is giving us a lot of headache, because you have our healthcare facilities telling us that in terms of our drug prices, that is too low because of inflation. But fortunately, the management just announced last month that there is 30% increase in our drugs price list for services and also for drugs across board. That is in public domain. Somebody want to clap? Please clap for us. I think we deserve that. Then limited acceptability of generic drugs. Yes, this is a very, very serious challenge over the years. Because in health insurance, we major only on generic drugs and not branded drugs. Most of the enrollees believe that generic drugs are fake, that they are not real, that they are faked, that they are not real. And so that perception, although within the system and through our stakeholders, we are trying to let them know, which we all know as pharmacists, that the fact that a drug is generic doesn't make it fake anyway. Because if it's generic and you also have a drug that is branded and they are all produced according to standards prescribed by the regulatory agencies, they will do the same thing for you. So that's the major challenge that we have within the system. But we are trying to address that. And I'll soon unveil to you what are the measures we have taken to address that. Then, of course, poor quality of drugs and products within the system. In reality, there are fakes. We have read that you can see a capsule being what? Filled with chalks, right? To treat infection. So you are going to have treatment failure, no doubt. National Health Insurance Scheme. Medicine Supply Initiative. In trying to address this, in addition to what government is doing, NHIS came up with stakeholders, and pharmacists were well represented, whether it's NAHIP, whether it's NIPRID, whether it's Federal Ministry of Health, all the, one you can think of, they were invited and they were part of the process that midwife this drug supply or medicine supply initiative of NHIS. And essentially, if you look at this diagrammatic representation, what it shows is that we are going to brand drugs, all the drugs that will be used in the health insurance ecosystem will be branded. Branded so that the confidence of the enrollees, right, can begin to know, to let them know that these drugs that they are that is dispensed to them is not fake, that is real. And then we're also going to have innovative form of financing, right, to fund the entire system. And thirdly, there's going to be some cost-sharing component. I will expand that as I talk. I have 5 minutes, Madam Chair has told me, so I have to run. But essentially what this initiative is all about is that for all the drugs that will be purchased under the system, to ensure that we have quality assured medicines in our journey towards UAC, that shall be true expression of interest and bidding. So pharmaceutical companies, it's open to both, local and foreign. It will be open and it will be advertised for them to participate and bid. And we'll pre-qualify so as many companies as are willing to for a particular project. Because the fact is that the volume of the purchase is going to be very, very large. When you talked about the health insurance ecosystem today in Nigeria, it's quite huge. Drugs also purchased using premiums from enrollees. And of course, some amounts of money through NHIS efforts, either from form of donations from development partners or multilateral agencies. We will work on that to ensure that those money comes in. All drugs purchased by healthcare facilities will be by healthcare facilities accredited by NHIS through accredited DMOs. What is DMO? It's drug maintenance organizations. Of course, there are going to be pharmaceutical companies, of which colleagues like you will participate, right? And they are going to manage the distribution and chain system in this initiative. Now, drugs shall be purchased from NHI's accredited registered pharmaceutical companies only, because we want to be able to trace every single drug that is dispensed to our enrollees to ensure that what they are receiving is of high quality. And then all drug purchases will have specific timelines. So once you produce, at so and time, we expect that those drugs should have what? Been utilized. That batch should have gone, and of course, we ask for another batch, and it will all be driven by data anyway. All drugs manufacturers shall carry the NHI's label. I've said that the packs and the blister itself shall carry NHI's label. Now, because of time, but I'll just speak to this 1 second. Cost sharing arrangement is such that at the end of the day, the enrollee will not bear any cost on this. It's either NHIS and the manufacturers will bear the cost, right? So at the point of receiving those drugs, there's no cost to them, right? And there will be they will not be part of the quotient. The second part, that one I've just explained, is full free to cost sharing. And the second one is the one that even the manufacturers will not bear the cost of producing those drugs. NHIS will not bear the cost of producing those drugs, but through donations and the EMAC funds that is made available will pay for bearing such costs. And it will go to the enrollees at no cost in accessing care. Now, financing, the money will come anyway from premiums, from donation, and so on. What are the way forward? This is about my last slide, so second to the last slide, is that we are going to be branding for NHIS and removing the labels of cheap drugs within the system. Thank you very much. That is what this initiative is trying to drive at. Then we enhance product quality we enhance quality drugs. That is what is produced for us as a nation and as in the health insurance ecosystem, right? Remember, I even told you that it's going to become mandatory very soon. So it's for everybody. It's not for a particular segment of the society. Then that will also eliminate fake drugs. Then it will make drugs more accessible, more affordable, through cost reduction. And then it will improve distribution channel system, whereby you know that once you see this drug, it's of genuine quality. And it will improve the ease of doing business for pharmaceutical companies. If you are here, you need to listen carefully. Because the key ministries of government were also involved in this initiative. Where pharmaceutical companies need a waiver, they will get the waiver. So that the cost that those products will come up will be acceptable to all. So all the critical stakeholders were involved in coming up with this initiative. In concluding, I would like to I'll read directly as my boss has written here. NHI is working assiduously to rebrand the scheme as the result-oriented organization in the health insurance industry. This will pave way to achieve our mandate of universal health coverage. We are confident that with your support, you, the pharmacists, that includes me, we will be able to summon these challenges and move rapidly to achieve the mandate of the scheme, which is universal health coverage. Thank you very much.
Thank you so much, Pharmacist Nuhu Ajodi, the General Manager, National Health Insurance Scheme. We appreciate your presentation, very enlighteningly rise to their feet. I know that we've had a very long day. Can you please rise to your feet? I crave your indulgence. And can we also move forward so we can concentrate ourselves in the front? Can we please move forward? Those at the back, it's going to be a very interesting session. The next speaker. As a recap, while people are moving forward, Pharmacist Nuhu Ajodi has told us that through the National Health Insurance Scheme, you can please sit down, thank you. We will have a resilient health system, and with the health insurance scheme, through the Basic Healthcare Provision Fund, we'll continue to ensure we have the universal health coverage. He also mentioned the drug-related challenges and, of course, preferred solutions. I would also like to add, Pharmacist Ajodi, that I would have loved to also see the role of the pharmacists in the National Health Insurance Scheme. I'm sure that everybody here has concerns that pharmacists are not involved, and knowing fully well that we have a GM that is our own person there now, I believe you should be able to make a case for us. If as pharmacists we have a say, we are sure, or we can be assured, the country can be assured that we will definitely have quality assured medicines at our communities, in our facilities, in our community pharmacies, or wherever we find drugs. They will be handled by the custodians of drugs that are licensed to handle them. Thank you very much. I'll be calling on Dr. AHMED NDAGI, FPSN, to please come and give his presentation. A round of applause for him, please.
Thank you very much. What about the pointer? Okay. Distinguished colleagues, the chairman of this occasion, distinguished colleagues, ladies and gentlemen, I'm pharmacist Dr. AHMED NDAGI MOHAMMED. Can I have my slides, please? I am an owner of an HMO. We call it Dallas Medicare. I think probably I've been called upon here because of my role in Niger State. And I own a TPA, a third-party logistics, Dallas Medicare. I'm not an economist, health economist, nor am I an insurance man. But I must say, the slide is not there. So the topic of discussion is universal health coverage, a Panacea, quality assured medicine, a Panacea for universal health coverage. When I was called upon, I said, I'm not an expert, but with an NGO, hello, this is not my slide though. With an HMO, Dallas Medicare, I've gathered a lot of experience. Bearing in mind that in Niger State, we have the contributory health scheme. That contributory health scheme, by special grace of God, I'm one of the leading, the Dallas Medicare is one of the leading TPAs enrolling in the non-formal sector in Niger State. So I think I would like to share my experiences with you here. Yep.
The name of the slide.
Quality assured medicine, a Panacea. Quality assured medicine, Panacea for universal health coverage. Sorry, I think there's a mix-up there. The airline, can I continue? Oh. They are working on
it. Technical team. Let's sit down. So, sir, while we are waiting for the slides to come up, you may just want to give us an overview of what your slides is all about. Thank you.
As an overview of my slides, first and foremost, I want to state that when you hear of universal health coverage, pharmacists seem to feel a little bit naive as if it belongs to another clan. But by the time I finish my presentation, you will see how critical the role of pharmacists are, particularly issue of quality assured medicine. There is no way you can achieve universal health coverage without attaining or getting quality assured medicines. So the outline of my presentation, we want to present the look for your slide. Okay, so it's all right.
So, our apologies. While we are trying to sort out the presentation slides for Dr. Ahmed NDAGI, FPSN, we would like to call on Dr. CHIJIOKE OFOMATA of the Department of Clinical Pharmacy, NNAMDI AZIKIWE University, for his presentation. Thank you. Can we give him a resounding applause, please? Let's encourage him, like my sister said earlier. Before he gets ready for his presentation, I want to believe that following the last presentation, we may have one or two questions. So I'll implore you to please still stay behind. They may have questions for you. When we're through, then we'll take the questions from the audience. Thank you. Sir, Dr. OFOMATA, sir.
Good afternoon, everybody. Chairman of the session, every other protocol observed. Access to the topic we have to deal with this afternoon is access to quality assured medicines as a panacea to universal health coverage. And that's the outline that we'll have to deal with. For want of time, we won't have to go through them one after the other. As an introduction, the goal of universal health coverage is to ensure that everybody, all people, obtain health services they need without suffering financial hardship. Every health service required, whether the woman or the man or the child is in the village, remotest part of Nigeria, remotest part of Africa, that person is entitled to have access to essential medicines. All of us will agree with the fact that after diagnosis and every other thing, without the right medicine, nothing has been done. The work of the physician, the work of any consultant could be rubbished on the table of fake and adulterated medicine, medicines that are not right, medicines that are not quality assured. The WHO reports that more than 50% of the world's population does not have full access, full coverage to essential medicines, with 12% of the population spending large amounts of their household income. Around this place in Nigeria, you will agree with me that our healthcare, majority of our healthcare, you're on your own. Yes, many people around us, over and over again, they go to the untimely grave because of the fact that they cannot afford the treatment that is required. And nobody's bothered about that. So Sustainable Development Goal 3.8 supports universal health coverage by aiming to achieve access to safe, effective, quality, and affordable essential medicines. A well-functioning universal health coverage system would ensure access to essential services, including safe, effective, affordable, and quality assured. Note those words: safe, effective, affordable, and quality assured medicines. Okay. So the WHO defines substandard medicines as authorized medicinal products that fail to meet their quality standards or specifications or both. Substandard medicines, authorized medicines registered by NAFDAC, but fails to meet quality standards or specifications, or both. But falsified medicines are those that deliberately and fraudulently misrepresent their identity, composition, or source. Those that deliberately or fraudulently misrepresent their identity, composition, or source. That is to say, when I take a product, it's a GSK product, okay, I label it as being produced by another company, or the composition, I use another ingredient. Maybe I put chalk in place of capsule, okay? Or any other composition aspect, any other aspect of the product, the actives not being what they ought to be. Looking at the statistics, every person has a right to expect that when they use a medicinal product, it should give the intended result. But because of the fact that we have challenges of quality assured medicine, especially in this environment, that right is not given to our people. In the year 2015, the WHO found out that alarming failure rates, about 64% for vital oxytocin injections. A large epidemic of dystonic reaction occurred in Central Africa due to mass substitution of diazepam tablets with haloperidol that are probably inserted criminally. Still looking at statistics, in 2019, Ozawa et al. Estimated that 12.5, that's in a systemic and meta-analysis research that they did, 12.5 of antibiotics, 12.4% of antibiotics, and 19.1% of anti-malaria in low-income stroke middle-income countries were substandard or falsified, either substandard or falsified. And then with an average estimated economic impact ranging from $10 billion to $200 billion. And we know that Nigeria is a key country in LMIC, low medium income country. Recent data from Europe highlight key neglected issues with the quality of medical services. The 7th study in sub-Saharan Africa found that 16.3 of 1,530 randomly sampled cardiovascular medications, anticoagulants, antihypertensive, and statins, that's about 250 of such patients, cardiovascular patients, failed active pharmaceutical ingredient content analysis. They brought these products, analyzed them, and found out that 16.3%, that's about 250 of those products failed active content analysis. Of course, a recent meta-analysis also found that 13.6% of essential medicines in low and medium income countries are all substandard, while regional prevalence in Africa and Asia comes to 18.7% for Africa and Asia 13.7% respectively. In 2019, it was estimated that 1 in 10 of every medical products consumed in a country like Nigeria is either substandard or falsified. That will give a lot of us some goose pimple. 1 in 10 of every product you pick up in our environment, either substandard or falsified. The highest prevalence of poor quality medicines was found in anti-malarials, given 19.1% and antibiotics 12.4%. Now, what are the causes and effects of poor quality medicines? Substandard medical products result from errors, corruption, negligence, or poor practice in manufacturing, poor GMP, poor procurement, not following regulations, poor transportation, and storage. On the contrary, falsified medicinal products result from criminal fraud, And that exists a lot in our environment. Although substandard and falsified medicines products have been traded for many centuries, in the last few decades, the problem has grown and become so complex that it should give all of us a cause for concern, especially now that internet sales, online pharmacy have been added to our environment. Substandard and falsified medical products are vetted for beneficiary. There are productivity gains. That person gets treated and he or she goes back to his or her work or the business that he does. Disability is averted due as a result of issues of quality using non-functional medicines. For want of time, we'll get to the next and we'll not waste time on this. Now, what are the benefits of quality assured medicines? We've talked about a lot of them. I will move and go to global access to quality medicines, what we call the Oxford Statement and Call to Action. The Oxford Statement and Call to Action. In September 2018, we had the first International Medicine Quality and Public Health Conference that held in Oxford, UK. And they came up, of course, delegates from a lot of governmental agencies, donor agencies, came together and came out with a lot of policy action concerning substandard and falsified medical products. Okay? The statement was born out of discussion from government, non-governmental, and the rest. I've talked about it. So they expressed support and recommended for the recommendation from WHO member states, which they accepted in 2017 at the World Health Assembly, that defines substandard and falsified medicines in public health terms. That resolution 67.20, calling on all member states and WHO organizations to strengthen national medicines regulatory authorities. Over here, our medicines regulatory authority is NAFDAC. So they are calling for all nations, member nations, to strengthen their regulatory authority in order to prevent, detect, and respond effectively. There are collaborations and harmonization on and on. For want of time, let me just begin to get to my conclusion. This slide should be available so on request from the organizers. In conclusion, our medicines regulatory authorities in Nigeria, like NAFDAC and PCN, has critical roles to play in having quality assured medicines in Nigeria through key functions such as enforcement of good manufacturing practice for manufacturers, registration, distribution and storage of pharmaceutical products, sanitization of the Nigerian genuine medicine supply chain. Okay? We have been on and on over the decades theorizing, making proposal. The time has come for us to take over completely those drug masks we've been proposing. The time for action is now. Otherwise, quality assured medicines will begin to elude us. There is a need for establishing pharmacovigilance and medicines quality post-marketing surveillance programs. You find out that most of the time, once a product is registered, the owners of the brand go on doing whatever they like. Post-surveillance, after giving certificate, there is need for continual check. Okay? And that means that NAFDAC needs to be empowered more through capacity and all that it takes. Enforcing regulatory actions to withdraw poor quality medicines from circulation. There is a need for regulatory actions to be enforced so that poor quality medicines will be withdrawn from source. Enforcement actions on non-pharmacists through quacks involved in sales and distribution of medicines. Without missing words, what is happening in this environment is that our regulators regulate the pharmacies. Did you hear me? Our regulators over-regulate the pharmacies. Some of the time you'll be wondering whether you are wrong by going to study pharmacy. Wouldn't you have gone and done an apprenticeship program and begin to do like others? So our regulators, both the PCN and NAFDAC, should begin to do what is in the rule, in the regulations, in the act that established them. enacting enabling laws to control and regulate practice of internet and online pharmacy in Nigeria. Currently, there is no law regulating or controlling internet and online pharmacy. And it has come to stay. There is nothing we can do about it. So the best thing is for our regulators to bring up enabling laws and regulations that will help us to control and make sure that the right things are posted on our internet sites or sold. Now, regulatory agencies should start regulating according to existing laws, contrary to current overregulation of pharmacies. That must be emphasized. NAFDAC to closely look at their pricing, the pricing of their regulatory activities. It is choking the pharmacies, very choking, okay? So their pricing, the pricing of their services to the pharmacies should be reviewed so that pharmacies can afford to do more. Consequently, ensuring the use of quality assured medicine is critical to universal health coverage, and investing in medicine quality assurance system and interventions is vital for the long-term success of universal health coverage. Increased capacity of medicine regulators in Nigeria is required so as to make them adequately prepared. When we are saying NAFDAC should do this, PCN should do this, there is a need to do what? To empower them, increase their capacity, give them every tool that they require so that they can perform effectively. Okay, thank you very much. These are the references, and thank you for listening.
Thank you, sir. Thank you so much, Dr. CHIJIOKE, OFOMATA of the Department of Clinical Pharmacy, NNAMDI AZIKIWE University, for that brilliant presentation. You actually took us through so many things, differentiating substandard and falsified medicines, and sharing the economic impact. You know, if you have $10 billion to about $200 billion going down the drain for falsified medicines, if that had been plowed into the economy, into the good roads, into housing, into lightning for the country, that would definitely help. Even for the pharmaceutical industry, that would definitely help to ensure quality assured medicines. You also stated the need for us to have our national regulatory authority up and doing. We must give NAFDAC a round of applause. Can everybody here please applaud? They're doing brilliantly well. Every day we hear something about NAFDAC. But they will not rest on their oars. Of course, it's not only, and of course, the Pharmacists Council of Nigeria. They are all doing well. Again, we will just encourage them not to relent on their efforts. They will have to continue to regulate and ensure that everything, people like engineers, you have doctors that are taking up that area of supply chain. We need to embrace it and know that the future is here for pharmacy. I would also like to call on the last speaker, last but not the least. Doctor, I believe his slides are ready. Hello? Okay then. So Dr. Ahmed NDAGI, FPSN, you have the floor. Thank you. A round of applause for him, please.
Thank you for having me once again. That's second time around. To start with, I want to quote the chairman of yesterday's occasion, the Ejimobia or something like that, the chairman of the day. So he said he doesn't want to be, he does not pray to give lectures when it is almost time for lunch, because everybody's attention will be somewhere else. Secondly, he doesn't want to give lecture when other people have given so much dossier of a lecture, because eventually you might be repeating what some other people have said. So I think based on that, there are some cut-cutting issues which I might have to skip in my slide during presentation. Hello? The last one, okay. Okay. Yes. This is the logo of the WHO on universal health coverage. say delivering quality health services is a global imperative for universal health coverage. Those are the series of units and of services delivered to achieve those objectives. These are my outline, introduction, reasons and requirements for UHC, measurement of the success of UHC and its indicators, brief introduction of quality assured medicine, health and economic impact, which is likely to be a repetition of some of the statistics given earlier on, which I might have to skip. Situation of fake drugs in Nigeria, challenges of universal health coverage, roles and responsibility of pharmacists towards achieving universal health coverage by the year 2030. And if I have time, I'll talk about Niger State model and then recommendations and conclusions. This introduction, I think I'll read this right through. According to WHO in 2019, universal health coverage is the organization of its system in a way that provides a specific health benefit package to all members of a defined population through provision of financial risk protection in the course of accessing necessary health care services. This concept was adopted in 2005 by the WHO, followed by adoption of Vision 2030 Sustainable Development Goals agenda as the 8th target of SDG 3, which is ensuring healthy lives and promoting well-being of all. That is SDG 3. And we have the 8th target as universal health coverage. The Nigerian strategy of achieving universal health coverage is through National Insurance Scheme. We have had the details of that. It was by the first speaker. It was launched in 2005. But so far, less than 7% of the population has been covered. I beg to have those, both formal and informal sector. Then, the need for sustainable provision of affordable, equitable, and necessary accessible health care services to the citizenry through innovative health care financial policies and legislative framework to cushion the effect of health care costs and user charges to its citizenry. This will increase productivity of workforce. Of course, by the time you reduce the out-of-pocket expenditure, there's a lot of saving, and you pool resources, there will be a lot of money around for you to improve the economy, and then there will be healthy population. So this will increase our productivity and workforce, thereby growing the economy, the wealth and prosperity of the country. So much has been talked about NHIS. They say NHIS services covered both formal, informal, and vulnerable sector. We have had that from the first lecturer. And they offer certain sets of minimum health packages to the beneficiaries. The formal sector was launched, as I said, in 2005 for improving funding of the health sector, among other factors. Also already mentioned, issue the Abuja Declaration that not less than 1% of consolidated revenue should be set aside for health care. That's the National Health Act. And actual implementation of the act took place in 2009 with the disbursement of 18 billion naira through the Basic Healthcare Provision Fund to all states of the Federation. This is very important because many of us pharmacists are skim out of some of this activity when we are not fully following what is happening. Universal health coverage means that all individuals and community receive the health services they need. Health services they need without suffering financial hardship. It includes all the full spectrum of essential quality health services from health promotion, prevention, treatment, rehabilitation, and palliative care across the course of life. Reasons and requirements for UHC. The major reasons why UHC was brought on board is to determine the most effective cause of disease and health in order to improve health of the people. disease and death in order to improve the health of the people. It's also to protect people from financial consequences of paying for health care services out of pocket, thus reducing the risk of pushing people into poverty. By the time people are ill, they will have to sell their properties, take their savings, even the savings for their grandchildren, sell off so that they can take care of their health packages. But by the time you put resources together and then you share the risk, this risk sharing helps a lot in preventing poverty, thereby enjoying health services and well-being. Many countries have made significant progress. It's worth noting that many countries have made significant progress. Several countries, however, were affected and during the COVID-19 pandemic. It disrupted availability of health and healthcare commodities. Many countries, even as that, many countries have also moved faster despite pandemic. There is, however, a general increase in costs. I think we had that yesterday from the DG NAFDAC, that there is increase in cost and there was element of profiteering too. Yesterday we had that during the course of the pandemic. Requirements for UHC. The basic requirement for UHC is competent health workers with optimal skills, optimal mixed skills at the health facility. And there must be a mixed skill within the outreaches and the community level. You don't concentrate in the health facilities alone. There must be a mix of skills. They should also be equitably distributed, adequately supported, and enjoy decent working environment. How do we measure the UHCs? Principally, we do that through assessing the proportion of population that access essential quality health services, and also the proportion of people that spend large amount of money, their disposable income, on health. Now, this is a very important slide which I want us to pay attention to. Measurement of success of UHC and its indicators through service area categories. This is the WHO recommendation. There are 4 categories of service that serve as indicators for assessing universal health coverage by WHO specification. The first of it is reproductive, maternal, newborn, and child health, which comprises family planning. As you know, family planning is very crucial. If an economy of a country is growing less than the population growth, there will be economic chaos. If an economy is growing higher than the population growth, then there will be economic boom. So there's a deliberate strategy of improving family planning services by universal health coverage. There should be antenatal care and delivery. Many of us do not actually go into issues related to health delivery, that's in baby delivery of children and antenatal care. Full immunization is also a component of the reproductive, maternal, newborn, and child health. Full immunization of children. And then health-seeking behavior, particularly for pneumonia, because pneumonia is one of the basic causes of death for children. The second vital category, service area is infectious diseases such as tuberculosis, HIV, AIDS, HIV/AIDS treatment, use of insecticide-treated nets for malaria prevention, adequate sanitation, etc. This is the second point. The third measurement indicator is non-communicable diseases. That's prevention and treatment of hypertension, diabetics, cervical cancer, screening and smoking. And the last but not the least is the service capacity and access. That means basic hospital access. How far can you access health? Location of a health center within your environment. Usually it should be less than 5 kilometers. Then the health worker density. We seem to have a lot of density of health workers in urban area. So, but most important point here, which affects us, is the accessibility of essential medicine. And that's why I bolded there. We'll come to that later. Health security health security in compliance with international guide. It's also one. So it's noteworthy that most of those indicators require quality assured medicine. If you look at them, all of them, they require quality assured medicines, equipment, personnel, and processes for optimal result. So whenever WHO is coming to make an assessment of UHC, they will go and use these success indicators. Now, introduction to quality assured medicine. We have had that. WHO pharmaceutical quality assurance may be defined as the sum of all the activities and responsibilities required to ensure that medicines that reach the patient is safe, effective, acceptable to the patient. Substandard and falsified medical products, including medicines, vaccines, biologicals, and diagnostics, represent a significant and growing threat to human health. So substandard and fake medical products resulting from error, I think we have had that, error, corruption, negligence, and poor practices in manufacturing, procurement, regulation, and transportation or storage of such products. So you can see some of the logistic problems associated. If they are not properly taken care of, then we'll have serious problems by the time the patient is taking his medication. So I don't have to go into that because I received the statistics. Okay, most fake and substandard medicine results from criminal. Okay, we have had that. Go. So impact of substandard and fake medicine. Yeah, those statistics were offered by that already scholar. But I want to stress on issue of this vital oxytocin, in which 64% of those oxytocin were found to fail. We all know oxytocin is supposed to be properly stored in a cool environment. And we all know our distribution system. Most of the people who are handling some of these things in our markets are people who are not properly trained. So when you hurriedly go to such places to acquire your medication, you will be in danger. And you can be sure that this statistic is true. So this is WHO Global Surveillance and Monitoring System for substandard medicine. This, I don't want to waste so much time. So he has also talked about this Central African mass substitution of diazepam with haloperidol. Now, the situation of fake drugs in Nigeria. Okay. Nigerian health experts are worried, both you and I are worried, over the influx of fake and substandard drugs into the country, which is endangering the public health. And that's why we're discussing the issue now. Professor Dora Akunyele of blessed memory was quoted as saying that fake drugs are responsible for growing number of cases of hypertension, heart failure, stroke, and illnesses in Nigeria. Our own Buddha Arrow was also quoted one time as saying 70% of drugs circulating in Nigeria are fake. Such drugs are believed to come from China, India, Egypt, Pakistan, and Indonesia. We all know, and we heard yesterday from the DG NAFDAC that they have taken further steps in convincing even the Indian health authorities to stop exporting substandard drugs to Nigeria. How effective that has been is a question that we need to answer here. There is a regular list of blacklisted companies that are published. So has it worked? Please, I think we need to discuss that. NAFDAC has also carried out what's called inspection of plants, both within and outside the country. They also carry out pre-shipment inspection of drugs meant for Nigeria. Towards achieving self-reliance and essential drugs, stakeholders have reiterated the need to boost and improve local drug manufacturing in the country for strategy of national drug security. That was stressed intensively yesterday. AHMED was quoted as saying it is important for stakeholders to work together and ensure that the drug market supply chain is sanitized. He also noted that NAFDAC is doing very well. Particularly yesterday, we heard about the traceability and trackability of vaccine up to the end user when the NAFDAC boss was making her presentation. So challenges of UHC. I think some of them were mentioned earlier. We have large proportion of population living in extreme poverty and are unable to pay premium. Large proportion of informal sector whose members are mostly uninsured. Most of the artisans that we have tried, myself as a TPA or HMO, we are struggling to enroll people into informal. It has been an equivalent tax. We have high dropout rate. People who got enrolled, but the following year you see that they drop out. And we have poorly funded primary healthcare system. You can see these are the kind of primary healthcare system as health facilities we have in some places. We have issue of corruptive tendency, low enlightenment, and large inequity, which has been mentioned earlier on. So these are some of our rural people. Okay, 2 minutes, okay. So these are, now, the Niger State model, which I'm sure is not different from any other state. But I want to stress that there's the establishment of Drug and Hospital Consumable Management Agency in Niger State to address challenges of supply of essential medicine at all levels, including private sector. That was established about 5 years ago. And they have done a lot of progress. And it is wholly pharmacists owned. And we have done a lot in that aspect. So there's also the creation of contributory health scheme, which I mentioned earlier on, to address the universal health coverage through compulsory financial contribution to both formal and informal sector, which I am a TPA or HMO in this organization. Implementing primary care under one roof to coordinate and address challenges and services of primary health care. These three institutions, by the time they work optimally, will give us a perfect universal health coverage. Roles and responsibility of pharmacists towards achieving the universal health coverage. This is also an important slide. As drug expert, please, we must show total commitment in these 4 categories of service areas that WHO indicators is used to assessing UHC by improving the key components requiring medicines and medical products. We must sustain the war against fake and substandard medicines also in order to attain this UHC. We must also evolve strategies and roadmap of collaboration. I know we cannot do it alone. We have to collaborate with other stakeholders in addressing challenges associated with attaining effective reproductive, maternal, and newborn child health, such as addressing the supply chain of family planning commodities. We must also address the issue of safe vaccine. I was so happy to hear the NAFDAC boss talking about taking full control of the visibility and accessibility of vaccine yesterday. Please give NAFDAC a round of applause. Roles and responsibilities continue. They're getting fully involved in provision of antenatal care services, that is particularly the ANC drug. Many of us who are in the hospitals do not even bother to see what is happening in our ANC clinics, where all these delivery kits and delivery packs are made available. Many of the health workers there take up that responsibility. But I must say that we must ensure that these products are of highest standard. The community pharmacists should push further for official recognition of community pharmacists. Or rather, let's say the PSN should push further for official recognition of community pharmacists as primary health care providers, particularly as vaccine centers, as experienced in other climes during the peak of the COVID-19. We all know during the COVID-19, we saw in other countries where pharmacies eventually were the vaccination centers for COVID-19. We must also push for that, not only for COVID vaccines, but for all vaccination processes. Community pharmacists are already providing family health planning options. The PSN should pursue official recognition, training, and retraining of farm direction. This is very important. Supply chain and management of drugs and other medical consumables, communicable diseases, poses a great threat. As you all know, most of our patients suffer from some of these diseases. If the drugs that they are using are not effective, we can never attain universal health coverage. So pharmacists must take malaria. And as I've said earlier, on issue of density of pharmacists in urban area, we need to address it so that urban-rural spread disparity will be minimized. The equitable provision of safe, efficacious, affordable, essential medicine not fail the nation in this direction of attaining our target of universal health coverage by 2030. In the light of the above, smaller countries like Kenya, I've visited Kenya, Sudan, and Ethiopia, Rwanda. If you see how they have streamlined their supply chain for essential medicine, you bore for them. Outcomes depends on availability, accessibility, and capacity of the health workers. If you don't have competent health workers who can do the job, universal health coverage can never be attained. And it must be people-centered and targeted care, not separate intervention. Share risk that can be, and this money can be channeled towards attaining more universal coverage. That's what that point means. It is imperative to note that universal coverage cannot be attained until we ensure availability, accessibility, affordability of high-quality medicines in our healthcare delivery system through strong supply chain network. Somebody has mentioned that we need to. So these are some of our people accessing health. This is health education program going on. This is a pregnant woman sitting inside an airline with her, and this vaccination going on. These are my references. Thank you for listening.
A huge round of applause. Thank you, Dr. AHMED NDAGI, FPSN, for your very, very, very robust presentation. I think you spent some 7 extra minutes after I sent 2 minutes to you. And by way of recap, pharmacist Dr. NDAGI actually stressed that for us to have success of universal health coverage, there are some 4 indicators: reproductive health, maternal, new child-born health. These has to be strengthened. We need to combat infectious diseases, non-communicable diseases such as diabetes and cervical cancer needs to be tackled. The service capacity and access to services also needs to be strengthened, especially HRH, that's Human Resource for Health. You shared with us the Niger State model, and I can say for sure that since pharmacists are the arrowheads at your drug and hospitable consumable management agency, you can be rest assured that you will have quality assured medicines at all times. So other states in the Federation can also adopt this kind of model. You took us through the roles and responsibilities of pharmacists in ensuring universal health coverage. And you stressed the need for pharmacists, community pharmacists especially, to forge ahead in their quests to ensure that their pharmacies are enrolled as vaccination centers. We can also start with the COVID-19 vaccination. You also stressed the need for the community pharmacists to be centers for family planning. Did I get that right? So family planning options can also be taken up at the community pharmacy. You have the PHC systems fully utilized. I will now throw the floor open to questions. Do we have anybody that has questions? Yes, 1, 2, 3. Any other question, please? 3 questions. First question, please. Hello, can you please? Okay, 2 on this side. Then we'll take the 2 as well. 4, 5. And please tell us who your question is directed towards. Thank you.
Good afternoon, distinguished colleagues. I remember pharmacist Mike Ogwefi, Lagos State, delegate to this national conference. My question goes to the representative of Professor SAMBO, which is NHIS Executive Director. You know, you said it that one of the major problems of this NHIS, especially when it comes to the level of community pharmacists or whatever, is when it comes to drugs. Most often, you discover that the drugs that we use are mainly generic drugs. And the patients often, they used to see it as not as very strong or maybe as effective as branded product. But what I'm thinking of is that, is there any way, I don't know whether there is a way where the drugs that are being dispensed, the generic drugs, there is a common way of sourcing them. That is from, a specified way of getting the drugs, so that what I'm selling in my pharmacy or outlet as a generic product, it may be the same thing the other of my colleague at the other end is selling. So I know that all of us are selling generic product, but we are selling something, though it's not written NHIS approved, but somehow it is NHIS approved. Because you discover these days that even when you have NAFDAC approved, there is still that, am I sure that this product is very, very effective? Thank you.
No, I think, do you want to take everything together? Okay, so let's take all the questions together then.
Thank you. My name is Dr. Danjuma Oinakababa. I'm the Director of Essential Medicines and Logistics, National State Primary Healthcare Development Agency. My questions are, one of the strategies to achieving maybe retain workforce in a health system space is to, in one of your, I'm directing my question to the last speaker. In one of the strategies to maintain workforce to prevent attrition from workspace is to have a dual practice. And in your recommendation, you made mention that pharmacists can locate community pharmacies, for equity redistribution of these community pharmacies to the hinterland, so that. But how are we going to do it when we are incapacitated? Because I'm saying that one of the strategies in health system strengthening is having dual practice, of which pharmacists are supposed to be at liberty, because that is the only incentive that you can give them to be able to keep them to also move spaces. But what are we going to do in order to meet up that one of the recommendations you've given, so that pharmacists can also have the benefits of providing services? Because whether we like it or not, pharmacists are needed. One other thing is that in primary healthcare settings, up north here, I don't know that of Lagos, community health workers are seen to be primary care providers instead of the core health professionals to be primary healthcare providers. If you go to health system strengthening, community health workers are supposed to be health-seeking behavior awareness raisers from communities to access care in the facilities. But the reverse is the case. What are we going to do? Because for providers, or maybe for HMOs or the NHIS to procure services, it has to be measured via all the indicators you've mentioned. And everything is tied to quality. If you don't have capacity to provide such services, can that be seen as a quality service? Because ab initio, they are not supposed to be service providers, but they are supposed to work within the community and raising awareness of patients who come to the facilities to access care. And another thing is that in your indicators, you get to understand that there are most of the indicators there are either process indicators or input indicators. Outcome indicators are not there. And that is the basis for measuring quality. I don't know how we are going to get out of this if we are to make progress. Thank you.
Thank you very much. The third, yeah.
Thank you very much. Yeah. The erudite scholars, the chairman of the session, distinguished colleagues, is another opportunity to speak directly with NHIS. I want to speak with NHIS. The success story of health insurance ecosystem in Nigeria changed with the advent of the state social health insurance scheme. I think we agree on that. And at a stakeholders forum in Nasarawa sometime, we designed something that looks like, my name is Pharmacist Somanu from Osun State. Yes. We designed what we can call health insurance under one roof in Nigeria. I was elated, very happy. But from your presentation, the touch of that health insurance under one roof is missing. When you are providing solution to the drug system, yes, I agree with you. The use of you don't use generic, your capitation is not enough to cover what the problem of health insurance is still the HCPs, generally. How much are you carrying along the state social health insurance operators in designing a solution to this drug problem in Nigeria? Thank you very much.
The fourth, yes. Thank you, madam. Please introduce yourself.
Okay, yeah. Okay. Good afternoon, everyone. I'm pharmacist Osa Afe, DPS, Edo State. My question is for the NHIS. It appears everyone in NHIS. But the area I want to look at is this. For accreditation of private facilities to operate, at least to provide NHIS services, I noticed that some of these private health facilities that have been accredited for it, they don't have pharmacists. So I don't know if it is what it should be. One of the criteria is that any place where drugs are being distributed or one way or the other, there must be what? A pharmacist. And that place, that must also be registered. So I don't know if in the criteria you use in picking out health facilities, private health facilities for accreditation to provide that services, whether you don't put this into consideration. Because I'm looking at it based on my state. That these are some of these, you see, private facilities providing NHI services, no pharmacists. So please, maybe
So when you say private health facilities, you are talking about those owned by medical doctors?
Yes, medical doctors.
So that
yes, that's what I
get
mean.
it
Yeah.
clearly.
That's owned by medical doctors. Thank you very much.
Thank you, madam. I think we have to move. Sorry, sir. Hello. Can you kindly sit and let us take... Madam, please, can you come forward? Thank you. Kindly sit, sir, so that she'll have the floor and you can have the mic after her.
Thank you very much. And I want to thank the speakers too. My question is directed to the person that represented the NHIs. When you talk about NHIs
Madam,
to
please,
pharmacists,
can you introduce yourself, please?
most pharmacists, what we talk about is like acadabra. Pharmacists are not really carried along. I want to know that I did my PhD in public health and my area of research was on NHIs, and I made some recommendations which they are using now, some of it. But you mentioned something about drugs. Now you're empowering enrollees. Enrollees are patients are enrollees. They must not tell them that it's out of stock. Yes, even if you agree, because they have been prepaid. But how much did you pay as capitation? And while empowering the enrollees, you are not empowering the pharmacists. When you said you will decapitate drugs now, when you even capitated the pharmacists are not carried along. Now you want to decapitate. You said you want to start branding, you are rebranding NHIs and you want to provide branded drugs for hospitals and even private health facilities. I don't know how to want to go about that, because the pharmaceutical companies you want to involve, I've been trying to investigate from some of the reps and some managers, because I'm involved in the drug revolving fund. And some of them are telling me that they've not heard anything about it. When we went to Abuja in April, I told the executive secretary, I asked the question that NHS price list is outdated. They said they are working on it. 2 weeks ago, they came to my facility. I'm a DPS in UIT Ilorin. And they said they gave us training. I asked again, they said, Madam, you know, it take a long time and they are still working on new policy. Now you are telling us that they have reviewed it. I don't know when will the paper come out. They reviewed the new price list and also the tariff and some other things and even the drugs. So I don't know when the papers will be out. Then I want you to tell us the strategy you want to follow on these branded NHS drugs. Because the companies you want to involve, are they buying their raw material somewhere else? I know it's at the top stage now. Because they said they are waiting for a waiver from Ministry of Finance or something. Please, I want to know the strategy that you want to follow to distribute the drugs. How do we get the drugs? I work in a hospital facility, public, and I don't know how the health facilities that does not have pharmacists will also have access to the drugs. Because you said we should not say out of drugs to any enrollees. If you say out of stock now, they will say that we should give them money to go and buy the drugs outside. Please tell us the strategy and how national drug policy will be followed. Thank you very much.
Madam, please, before you drop the mic, can you please introduce yourself? Thank you, ma'am.
I'm Dr. Mrs. Medubi Grace, from a director of pharmacy from UIT Ilorin. I work with NHS facility there now. Thank you.
Thank you very much, ma'am. Yes, sir. So that will be the last question from you, and then we'll take responses from the speakers. Thank you.
Good afternoon, all. I am pharmacist Uche Nokoye.
Can you face the audience?
I am pharmacist Uche Nokoye, a dedicate from Edo State. So I have two questions. The first question goes to Dr. CHIJIOKE of OFOMATA, and it is quality medicine. When PCN allows non-professionals to handle medicines in Nigeria, like the quacks, how can we ensure quality medicines when PCN allows non-professionals, like the quacks in the open drug markets, to handle medicine? Because I see it as nearly impossible. Then this one question goes to the last speaker, who spoke on universal health coverage. How do we ensure universal health coverage in Nigeria when we are known as the poverty capital of the world? How do we ensure universal health coverage in Nigeria when we are known as the poverty capital of the world?
Thank you very much. I think Dr. Ndoji would start. Thank you.
Thank you very much. Modalities for sourcing them. The first pharmacist from Lagos, you are talking about what can we do to kind of source, what's it called now? Unbranded drugs, right? From a genuine source, right? Thank you very much. We know that, you and I know, sir, that if you look at the distribution chain, in spite of the distribution policies, that we don't have a perfect system yet. We know, isn't it, that a lot of drugs are circulating within our society, and that net does not capture most of the drugs, right? Yeah, so that is the challenge. And what we have come up with, the NHIS Medicine Supply Initiative, the last speaker in addressing this, I also addressed that, said that how does it align with the National Drug Supply, right? Guideline. I want to let you know, while addressing that, Madam, that representatives of that initiative were also part of those that midwife this NHIS Medicine Supply Initiative. And to address yours, sir, well, I think we have an open market system. It's a fact. And if we don't regulate our distribution system, we are not going to be able to take that. Because people import parallel, isn't it? Even outside the regulatory, they are able to beat it. We read about that regularly. So we must have a system that we can enforce. NAFDAC is doing their best, but we always have these grassroots agents within the society that will try to beat the system. That is true. So this initiative, it's a solution to addressing what you have mentioned in such a way that we have a mechanism, right, to source the unbranded drugs from recognized pharmaceutical companies. And like I told you during the course of my presentation, I said both local and foreign pharmaceutical companies I welcome to participate. As a matter of fact, during the course of drafting the guideline, they had representatives. They had representatives in the committee. I think that answered that. I will move to the next question, which is providing service. Private clinics or hospitals not having in-house pharmacies. It's part of our guideline, accreditation guideline, that any hospital, whether private or public, that want to provide pharmaceutical care in the course of, our enrollees assessing care, must have an in-house registered pharmacist. It's part of it. But I must also sound this. This is a family meeting, isn't it? Let's tell each other frank. I don't know where some of the facilities get their pharmacists from during the course of accreditation. And they will be there. So I think we have to address ourselves in-house. I will not say more than that.
That is a big one.
Thank you very much.
A big one.
Then the next one is Shia, my dear brother from Osun State. You are right. But let me tell you, sir, that a month ago we met in Port Harcourt. And of course, even the Shia, the drug initiative you are talking about, you know that the ES from Osun State is the current chairman of the state executives of health insurance agencies in Nigeria. Currently is the chairman. He was there, and health insurance under our room met in Port Harcourt. I was there just barely 4 weeks ago. So your concerns are being addressed. The policy document was unveiled, and very soon it will be disseminated to the public. So we are doing all we can. And I also want you to know, sir, that yes, you are right. The health insurance ecosystem has changed with the incoming of the states. Let me remind you, sir, which you are aware, that it's the idea of NHIs that we must decentralize to states. That states should be in the driving seat in the implementation of health insurance. So we are doing all we can. But sometimes bureaucracy will crop in. Even when you have a document, it goes through approval processes. And there's nothing you can do about that. But not that we are not doing anything. We are doing a lot. Thank you very much.
Thank you very much.
I still have another one. I'm not done.
So.
I think I have number 4 now from Madam, the last speaker. He's talking about pharmacists are not carried along. Yes, thank you so much. I'm a pharmacist. Even though I'm within the system, I will soon retire too. And I will come back to this practice. I started with this practice and I will finish with this practice in the course of my lifetime. So we are concerned about management, the new management. I'm part of that management. I can speak to that to you, frankly speaking. Professor MOHAMMED SAMBO is doing a lot of reforms. And part of the reform is to ensure that pharmacists participate in provision of care in our journey towards UAC. The drug aspect is capitated. You mentioned that rightly, through what we call global capitation. Right? We want to unbundle it. Unbundling means here, what is the part of that capitation to the primary health care providers? Right? Give them that. Then the component of the drug will take it out. When you unbundle that, it's going to have a, what's it called? Dramatic effect in the pharmaceutical businesses. I'll give you an example. I'll cite one. If you look at the Basic Health Care Provision Fund implementation today, right? There are thousands of enrollees in communities, in wards, right? If you unbundle it and our enrollees are given this chance, which is going to happen very soon, it's a question of time, to fill their prescription in pharmacies, in inbuilt pharmacies, they have an option. So it will now be competition, right? I can assure you that when we open shops or premises in the rural areas, you have a patronage. Because there is no word, even currently as I speak, the man from Osun State can allude to that you have in a ward, you will not have less than 10,000 enrollees. Am I lying, sir? Thank you, sir. And it's already happening. It appears to be slow, but it will happen, madam. I assure you that. It will happen. Thank you very much.
Thank you so much, Dr. Ndoji. Personally, I have faith in the rebranded, please have your seat, sir. I have faith in the rebranded National Health Insurance Scheme. You've said a lot here, but my first take home is, where are those people that come out? Who are the pharmacists, quote and unquote, that come out when registering these private outfits and claim they work for these places? Those private entities owned by our cousins. So if someone comes out and claims he or she is a pharmacist and NHIS registered that premises, then it is not the fault of anybody if we are left out. Because at the end of the day, that person is just like R&G. R&G that PCN is frowning at, the Pharmaceutical Society of Nigeria is frowning at. Why should you, because of how much? 300,000 naira, you throw your certificates under the bus, and then someone is the person that will be using that certificate, quote and unquote, forever, because they will take pharmacy technicians to be operating in that facility. So we are throwing it back to the house for us to discuss amongst ourselves. We should frown and say no to those of us, and if anybody is doing such, we should let the authority or relevant authorities know. So I think that should address the issue of our non-involvement in those places. Of course, we don't want to believe that there will be some people that will be cutting corners. Again, we have faith in the new National Health Insurance Scheme, and we hope that this will also be addressed. Thank you very much. So the next question, I'm going to throw that at Dr. CHIJIOKE OFOMATA, and it's, how do we ensure quality medicines when Pharmacists Council of Nigeria allow charlatans handle these medicines? Sir.
Okay. Thank you very much, the young man that answered the question, asked the question.
No, it's from the audience, actually. I just wrote it down.
Yeah.
It was from the audience, but I'm throwing this at you. Okay,
one of the questions he asked, yeah. The issue is that all of us know how we started in this nation, how pharmacy profession evolved. And right now, it is coming back to hit us below the belt. There are regulations to that effect. And I must tell you that our regulators, they have started, okay, looking at those charlatans, looking at those non-professionals. But a lot still need to be done. Hello? Let me deviate a little to add to what they've just said. Suffice it to say that a lot of our young people, young pharmacists, some of us are 40 years, 30 years, 20 years in the profession. People that we're, preparing to hand over to. They are the same people that go to register those people. Let's call a spade a spade. They are the same people that go to register those people. They will register, this is my uncle or whatever, or somebody will bring the person. And I used to tell them, once you surrender your certificate and become a superintendent pharmacist, anything that is done as a result of drugs in that institution, you are held responsible. Assuming you gave somebody and they're importing with your certificate, once there is any problem, nobody knows about any MD. Nobody knows, the regulators don't know any chairman. the person they know is the superintendent pharmacist. But we take all these things for granted. So while we are looking up to the regulators, PCN, NAFDAC, even PSN, to do their work, what are we doing to help ourselves? Okay? In fact, in some states, most of our states, you come in, you don't see pharmacies sitting down in any pharmacy, in most of the pharmacies. Most of them are covered by what? Register and what? Go. Okay? They come to Port Harcourt, they register a pharmacy, and they go to Abuja, they will be working. So it is a complex problem. In fact, the things that are holding us down today as pharmacists is caused by all of us, including me. We are the cause of our problems. Even the charlatans, who was the person the young pharmacist that asked that questions? He has gone. You see? He didn't wait for his question to be attended to. Where is he? Okay. Even those charlatans, it is we pharmacists that go to support them. Okay? We aid them to open up retail pharmacies when the law says they should not. We young pharmacists. Yes, we all know in our various areas, in all the states, including Lagos, Abuja, it happens. So, of the game. Our regulators are not immune to this. Our regulators also have their shortcomings. But it can only get better. We are hoping and praying that NAFDAC in her regulatory activities will continue to do better. PCN on a day-to-day basis will continue to do better. Because once we have laws that are okay, to enable us to take back our profession. But the problem is living according to those laws, regulating according to those laws, practicing our profession according to those laws. So everybody has a role to play to enable us to take back our what? Our profession. Pharmacy belongs to our father, if I may use that word. Okay? This is your inheritance. Why throw it away to the dustbin? Because of a pot of porridge, if I may use that word. Why throw it away because of maybe 500,000? You throw your certificate to the dustbin and just go wherever you like. Let them do with my certificate whatever they wish they will do. So basically, it is wrong. We are the people causing it. Because it won't take anything to flush out all the others, those that are not professionals. But we, professionals, we go and support them. And they will be doing a lot of things that they are doing, which is against the law.
Thank you so much, Dr. CHIJIOKE OFOMATA. Thank you so much for your brilliant response. Dr. AHMED NDAGI, I will throw this question to you. How do we ensure universal health coverage when when the income per capita for the country is abysmally low? Thank you.
Yes, that's a very good and important question. As I said, I'm not an economist, neither am I an insurance expert. But as I mentioned during my presentation, one of the basic requirements for economic growth is, comparing economic growth with population growth. By the time our collective output, our gross domestic product, our gross national product, those are indicators of economic development. By the time this index, this percentage, is lower than our population growth, we are in a big problem. Because you seem to be doing a lot, but because of the population growth, your impact will not be felt. So I think our population growth is 3.8%, 4% or thereabout. But our economic growth is our 2 point something, 2 point. So by the time you extrapolate, you know, whatever you are doing, you are just struggling. And that's why our population control is very important. And you can see under UHC too, one of the indicators is to check population growth. And that's why we are advocating the decentralization of population services to cover our community health pharmacies. They should be trained. They should be fully involved in handling issue of contraceptives and whatsoever. So that, because they see and attend to large number of people, whether we like it or not, they are already into it. So let's formalize and find a way of increasing our economic output and reduce our population growth. Then there was also question of disparity. Do I handle all the ones? Or,
So I believe that has been addressed.
Okay,
The
issue of health workers.
Okay, yeah.
Yeah, that there are in some climes or a part of this country we have community health workers who this person considers as if they are not proper health workers. This CHU and whatsoever. I want you to understand the concept of tax shifting and tax sharing, which is developed by federal government, that health workers are grossly inadequate. You can see from the slides we presented, our 40 million health workers are required globally. And Nigeria is part of this problem, and we are not able to get it. So federal government, in its own initiative, felt that we should find a way of giving out certain responsibilities to others while we monitor those people. And that's why they have issue of health, community health workers that can handle basic things where there are no nurses or midwife. And so they call them health workers in other places. Or in the recent sense, if you look at WHO recommendation, they are not health workers per se. But they are solving certain problems. That means if you are properly trained and they can follow the general order, they call it GO for their services. By the time you reach a level, just to handle malaria, fine. But if you see certain signs and symptoms appearing on a patient, please refer. That is in their GO. But that is not happening. I want to agree with him that it is not happening. Many of these community health officers conduct one of the worst atrocities in the villages because they assume the role of pharmacists, they assume the role of doctors, and they carry out atrocities, including abortion and whatsoever. I'm sorry to say that. Evidences of ruptured uterus. When I was in the hospital, you find such cases coming up, and they tend to give oxytocin both parenterally and then even intramuscularly, and before you know, a patient is having some complications. That's when they come back to the general hospital. So I agree with you, but government, in its own wisdom, felt that health workers are not really going to the rural area. You have already said that. How I wish the registrar and even the president of PSN is around. Because there's this law, the Modified Pharmacists Council law, which is supposed to come on board. It gives us the opportunity to have, if you are in the rural and urban area, within certain distance within your own premises, you're supposed to have another pharmacy so that you can effectively manage. If such thing come to bear, it will reduce this problem of drift. Everybody stay in the urban area. There was a question also on the outcome indicators, whether the areas I've mentioned here are just outcome indicators. Fine and good. I didn't want to go to those details. The importance of that slide is to tell us that by the time the WHO is coming for surveillance of what do you call it, universal health coverage, these are the things they look for. And I'm sure they have key performance indicators that they look into, which it's not for us here. But we must know that all these service areas, 4 of them, issue of drugs are involved. And many of us are not bothered to look into them, to use the opportunities that are available for us so that we ensure high quality medicines are available in those areas. That is the objective of that slide. And then finally, there was also a question that, okay, that Nigeria is the poverty dawn of the world, if I heard him. Did you hear that question? Sorry? He said Nigeria is, how can we achieve universal health coverage when Nigeria is the dawn of the...
Income per capita is
okay,
low.
so I think I've answered that question.
That.
Yes, I've answered that question. Yeah, so thank you very much.
Thank you very much, sir. A round of applause for him. A round of applause, please. I may also want to add that for the CHIJIOKE who are community health extension workers, those that have gone to the universities happen to be the community health officers. They are governed by, they have a Bible. What do we call them now? Is it their general order? So it may be necessary for states to have some form of health sector reform laws where everybody knows, you can maintain your lane. And again, if you have some form of HRH profiling, and then okay, this category of people, this is the number of CHIJIOKE I have, number of this I have, and it will be obvious that, say, the pharmacists are not enough or they are in excess. Then you'll be, again, if they have a directorate or anything in existence, they can also try to ensure that there are deliverables. You can give your deliverables to your officers to implement. So it's more of it's more of teamwork. Until we start to work as a team, things will not work very well. We have come to the end of this session. I'd like to thank our speakers, starting from the lead speaker, the GM NHIS, pharmacist Nuru Adoji. The other speakers, Dr. Ahmed NDAGI and Dr. CHIJIOKE of OFOMATA, they have done justice, I believe everybody would agree with me, to the topic, access to quality assured medicines as the panacea to universal health coverage. We cannot discuss this in one day. It's something that we'll still go back home and digest, and we hope that at the end of the day, any resolutions that we have agreed upon would help to improve the quality of health of the patients that we serve, because that is paramount at the end of the day. Thank you, everyone, and have a good evening. Please, can you come forward so we can have a group picture? Thank you.